Thank you very much for the kind introduction, and thank you for the invitation to speak here today. I really appreciate it. My name is Elad. I'm from NYU Langone, and today I'll be talking a little bit about some of our recent work from breast cancer brain metastases. So just a little bit of background before I start about breast cancer brain metastases. So approximately 10 to 30% of breast cancer will metastasize to the brain. And the estimated median overall survival for these patients is 8 to 17 months. So although breast cancer has been thought to be the more favorable metastases to the brain compared to lung or melanoma, still the median overall survival is not very great. And interestingly, the majority of these patients will have CNS progression that leads to their death. So up to 61% of patients with brain metastases will succumb to death because of the brain metastases rather than primary progression of the disease. And so that led us to develop a project, and the goals of this project were twofold. First of all, we wanted to explore predictors of long-term survival. We wanted to really understand why do some patients survive much longer from breast cancer brain metastases while others do not. And also, we wanted to explore kind of the CNS-related mortality. So what are kind of the drivers or the clinical markers that leads to patients to die from CNS-related causes? And so to do that, we developed a project. We collected our data prospectively via our point-of-care registry from 2012 to 2022. And we collected demographic, molecular, treatment, imaging, stereotactic radiosurgery procedures, systemic therapies. And we used all of that information and we analyzed it via the fine and gray method for competing risk. So for those of you that are not familiar with that method, the Kaplan-Meier method is a method for analyzing survival curves, but it doesn't take into account death as a competing risk. So many therapies might fail, or the patient might not have a chance to fail the therapy because they died before that from another cause. And so we use that analysis method because it captures real life scenarios of patients more accurately. And so in summary, in our study, we had 190 patients with 931 tumors that underwent 429 SRS procedures at our center at NYU. And so we identified patients who were managed with SRS and defined those long-term survivors as the patients who survived past 5 years from the date of the first SRS procedures. And while those that did not were defined as short-term survivors. And CNS death for this study was defined as neurological decline that was due to focal intracranial disease, either a seizure or a focal neurological deficit, or if there was a general decline that was most consistent with intracranial disease progression and their primary disease in the breast was stable. So if either of those two criteria were met, and the patient was defined as death from CNS-related disease. And so what did our results look like? So the median overall survival for patients in the entire cohort was 25 months from their initial SRS date and 130 months from the primary cancer diagnosis. And that is really significant compared to the 8 to 17 months median overall survival that was previously cited in the literature. And we also looked at, very interestingly, we also looked at patients who first presented at our center with synchronous metastases. That is, the patient had no history of breast cancer whatsoever, and they came in with some symptoms, or they had an MRI, and they discovered that they had already metastases to the brain, versus patients who were asynchronous, and that they had a prior diagnosis of breast cancer and then later developed brain metastases. And we found that, very interestingly, there was no significant difference in survival between these two groups. And that really speaks to the high salvage power of SRS, that even patients that come in with already brain metastases without ever having any diagnosis of breast cancer have similar overall survival. And not all breast cancer subtypes are created equal. As previously discussed by Dr. Lukewald, breast cancer, triple negative breast cancer is the most omnious subtype and carries the shortest median overall survival, while hormone positive, hormone receptor positive, HER2 positive breast cancer subtype had the most favorable median overall survival. And so kind of we wanted to look at what are kind of the predictors of increased survival in patients that come to clinic. So patients who have hormone receptor status positive, as well as patients who were treated with targeted therapy, or patients who had the Karnofsky performance status over 80 at their initial SRS, and patients with less than 3 brain metastases were all favorable prognostic markers for increased survival after treatments. And comparatively, patients who were treated with chemotherapy alone carried a shorter median overall survival. And that was generally all breast cancer subtypes, but we also wanted to look at, as I said, the most aggressive subtype, triple-negative breast cancer. It kind of doesn't have as much attention to it as kind of the more favorable subtypes, because there are no hormones to target, no hormone receptors to target, and less therapies available. And nowadays, the gold standard in terms of systemic therapy is still chemotherapy for triple-negative breast cancer in many centers. So we wanted to look at some of the patients in our study underwent immunotherapy treatment for triple-negative breast cancer. It's now being studied for in many clinical trials, but interestingly, patients with brain metastases were excluded from these trials. And so some of the patients at our center had off-label treatment with immunotherapy and with brain metastases. And what we found is that patients were treated with immunotherapy actually carried a much greater overall survival, of median of 23 months compared to 10 months of patients who were not treated with immunotherapy, as well as the breast graded prognostic assessment grade, which is kind of a prognostic marker that takes into account age, the KPS score, active systemic disease, and the number of metastases. So a score of greater than 1 was more favorable. And so now we move to the kind of the more interesting part of the study, the long-term survival. So previous study, we defined it as 5 years. Previous studies have defined it as 2 or 3 years. And we really wanted to push the envelope to kind of see if there are any clinical predictors for patients who survive past 5 years. And what we found is that 17% of the patients in our cohort survived past 5 years. The majority of them were, as expected, hormone receptor positive patients, HER2 receptor positive, and only a minority of them were triple negative because of the aggressive nature of the disease. And so not an insignificant amount of patients survived past 5 years. So that raised the question to is there a cure, a potential cure for the disease? The question only time will tell, but 31% of the long-term survivors and 4% of the total study population required no systemic therapy or local therapy for breast cancer, for either the primary disease or the brain metastases after the initial SRS. And so this is a very interesting point that we try to raise, and only time will tell as systemic therapies advance and more accurate diagnostics advance, but something very interestingly that we came across. And as mentioned before, for the overall survival, same things are active here. So patients with hormone receptor positive and patients with targeted therapy are both clinical predictors for long-term survivors. And now to the cause of death. So overall in our study, we identified 100 patients that died, and we were able to ascertain what was their cause of death. So only 11% of the patients in our study died secondarily to CNS-related causes, while the overwhelming majority of them died from either primary progression of the disease or other causes. And for a minority of patients, the cause of death could not be identified. And so this raises the question, what are the predictors for CNS-related mortality versus non-CNS-related mortality in patients that come to the clinic? And for our analysis, only development of leptomeningeal disease was a predictor for CNS-related mortality, while patients having triple-negative disease, a KPS score of less than 80, active systemic disease, and extracranial metastases were all significant predictors for non-CNS related mortality. And these are essentially just proxy or surrogate markers for active systemic disease rather than specific markers. That's what we postulate in our analysis. And now you might ask yourselves, what about the cause of death of long-term survivors? What did that look like to patients that survived past 5 years? What did their end of life care look like? And interestingly, none of the long-term survivors died from CNS-related disease. And so this is kind of a graphic to illustrate that. The red line marks the 5-year point, and the yellow dots mark the patients that died from CNS-related causes, while the green dots are patients that are still alive, and the blue or cyan dots are those that died from non-CNS-related disease. So if a patient really survived past 5 years, we did not identify any patients that died from CNS-related causes. And in our analysis, 66% of the patients had what we call distinct tumor metastases, so new metastases to the CNS at a different site that was previously treated. The median time to new brain metastases after initial therapy with SRS was 9 months to patients surviving less than 5 years, and as expected, much longer for patients who survived past 5 years. And that's perhaps because their systemic disease is more better controlled. And just analysis of new tumors to the CNS system, just relying on the number of brain metastases is not enough. Previous studies have utilized just the number as a marker to if the patient is more likely or less likely to have new metastases in the CNS. But really, new literature in the last few years has identified that it's really not the number of metastases that acts as a surrogate marker for identification of new tumors to the CNS. But again, it's the total tumor volume, not the number, that correlated with overall survival and local control. So we wanted to take that idea further, the idea that it's not just the number of tumors that can help predict if a patient will have more tumors to the CNS, but it's the volume. And we utilized both of these notions, and we proposed the adjusted tumor burden, which is basically the total intracranial tumor volume of the sum of all the tumor volumes divided by the sum of the metastases. And we found that it's really a significant marker for a predictor for if a patient will develop new CNS metastases. So patients that had an adjusted tumor burden of less than 3, that is, they had a high number of metastases with small volume, were more likely to develop new metastases. And we think that this is because active systemic disease that is sprouting new tumors to the CNS, rather than the disease that has just one big giant tumor in the CNS, is really a proxy marker for active systemic disease. And so we think that is the real reason behind the adjusted tumor burden correlating with that. So lastly, tumor control, the tumors that were treated with SRS, what did their control look like? So only 4.6% of them progressed after initial SRS therapy, 93% at 2 years. And again, none of the long-term survivors had local progression of the tumors that were treated with SRS. SRS has some side effects, and what did that look like in our analysis? So 3.2% of the patients or the tumors that were treated actually had adverse local radiation effect, with the majority of them being asymptomatic and were treated with a short course corticosteroid, and the overwhelming majority of patients and tumors that were treated had no local radiation effect. And of course, leptomeningeal disease. 31 patients, 16% of the patients in our analysis developed leptomeningeal disease after diagnosis of brain metastases. The majority of them, 26 patients, had disseminated disease, while 5 of them had focal leptomeningeal disease. And 13% of the patients in our analysis underwent whole brain radiotherapy, all for the treatment of leptomeningeal disease. So we try to reserve leptomeningeal disease, whole brain radiotherapy treatment only for leptomeningeal disease at our institution, and proactively treat with SRS whenever possible, given the dose volume constraints. And the median overall survival for these patients was 19 months. And again, none of the long-term survivors developed leptomeningeal disease. So what are the conclusions of our analysis? So in the modern era, breast cancer brain metastases patients can achieve longer survival than might have been previously anticipated. And importantly, most patients with brain metastases did not die from CNS-related disease, and none of the long-term survivors died from CNS-related disease. And so with better control of extracranial disease and advancements in systemic therapies, along with aggressive local therapies such as SRS, a chance for a cure might exist for a subgroup of patients with breast cancer brain metastases. So I would like to thank all of my mentors and colleagues, and I'm truly indebted for all of their work. And I'll take any questions later if you guys